Assalamualaikum. Good evening, doctors. So welcome to our last session of this recalls based discussion. And today we are going to cover some very common topics. Of course, we cannot cover the all dermatological conditions in our all X-rays and all ECGs. But of course, I'm trying my hard to cover, the most important things which we are usually getting in our exam, or for exam point of view, what they usually ask especially. So we are going to cover those topics here. So let's have a look. The first, okay, Dr. Tahira is here. Let her join and then we'll start. Okay, Assalamualaikum, Dr. Tahira. We have just started. We were just starting with the first page. So we are going to cover here the very common dermatological questions or pictures which we are going to see in our exam. So only for exam point of view, of course, the things which we are going to cover here. So the first picture you usually get for psoriasis. So for psoriasis, of course, we know very well it can happen anywhere, but the very common manifestations is over the joints where we can see psoriatic arthritis. So make a habit of, Googling the images, especially if you are covering the derma, especially, so that you need to see different presentations of this one, because psoriasis can be anywhere in the body, but most likely we will find psoriasis in the scalp region, and we will find the psoriasis in, especially if you're considering, we can find the psoriasis in joints, over the joints. So this is the very common presentation of psoriatic arthritis, and this is the very common presentation when we usually find it on scalp. So just try to look at the pictures again and again, so you will have an idea, okay, what kind of crust we are going to see if it's a psoriatic condition. Of course, we will find crusting, but crusting we will also find in dermatitis, crusting we will also find in seborrheic dermatitis. In keratosis also the starting thing is crusting, in eczema also starting thing is crusting. So once you see the images again and again, you will see the pattern, how it actually goes. It will limit it to a very confined area. It's not going anywhere. Say for example, if you can see, it's only particular over the knee joint you are going to see, only over the temple region if you are considering here, or in the form of patches you will see, and most likely it's a white kind of plaque, white kind of crust you are going to see here. And if you are going to remove this thing, so just like a dandruff, it can be easily, of course it cannot be easily wiped out, but you can see the upper layer is going to, you can easily wipe out that layer, but of course the base will be there and it will become thickened again and again. So just look at the pictures of psoriasis. Mostly presentation you will find behind the scalp region and over the joint. Psoriatic arthritis is very common in our exam point of view. We usually get this one. Then we have this one, seborrheic dermatitis. So seborrheic dermatitis, again here, they usually give this children pictures, but you can find, of course, seborrheic dermatitis in any age of the patient. It's not particularly about this one, but usually when we find in babies, like in infants, we usually say it's a cradle cap. So of course, if it's there in the adults one, you can say adult scalp is also involved, but normally we will say it's a cradle cap because it's the most likely presentation we will see in, especially in children. So if you could just differentiate this with psoriasis, what you can find here, it can also be on the scalp region, but where the sebaceous glands are more, where you will find mostly the area where the sweat formation is more, you will find seborrheic dermatitis over that area, because seborrheic, it stands for sebaceous. Seborrheic is actually a word which comes from the sebaceous gland. And of course, this dermatitis is a condition, is the skin condition. So mainly wherever we will find increased amount of sweat glands, you can think about this seborrheic dermatitis. And if you could just clearly look at the picture, you can see this dermatitis is always give you this yellowish appearance, this honey crusted appearance. So if you can see honey crusted, golden crusted appearance, if you see over, especially over those areas which are very rich in sebaceous gland, like scalp, like hands, and like underarms, like shoulders, like creases, where you will find more amount of sebaceous gland. So over those areas, you will find a seborrheic dermatitis. Of course, it's a lifelong condition, but it can be easily cured if we can, come across with the early stages. We can cure that one. So look for the pictures of seborrheic dermatitis on and off, so you will get a clue that, okay, I need to differentiate it from psoriasis. So what are the parameters on which I can differentiate it? Mostly you will find it in honey colored or brown colored, or especially golden colored crusted. The next one, this one we have already covered in theory as well. Basal cell carcinoma, always you will find it on the face region, most commonly over the nose, most commonly over the eyebrows, especially angle of the eyes. You can find on upper lip, you can find, so mostly on this nose portion. So anywhere on the face, if you can find this one, you can think about always basal cell carcinoma. Plus, what was the very important point which we have covered in theory as well, it would always give you a pearly shine appearance, like pearl. It must be in the center. The center portion must be a shining one, and you will always find a clear-cut demarcated area. So if there is a clear-cut demarcated area with the central cupping inside, and that's a reflective one, pearly reflective one, you can think about always basal cell carcinoma. Melanoma pictures are very common as far as our exams are concerned. So melanoma pictures, you will always find there will be a very small shot. They must not be giving you the whole picture of a man who's having this melanoma, or a female. Usually very fair people, they are usually having this melanoma and they are collected together. So it's nothing, they are the melanocytes actually which are giving pigment to our skin. But if they come across together, it's a cancer form, it's a malignant form, but it is usually not going to metastasize, it's going to stay there. So if you find something like this one, like too many moles are collected together at one point, most commonly over the skin of the hands, most commonly on the forearm, we usually find this one, but it can be there anywhere in the body. So you will say it's a melanoma. So melanoma pictures are very easy to differentiate. For systemic lupus erythematosus, SLE, you will find always a typical butterfly rash on the face. So usually also in exam, you will find a butterfly rash. They are not going to give you any rash which is not going to resemble with this butterfly pattern, because anyhow, this lupus, if we are considering lupus nephritis, they can also present with the rash, but that rash sometimes cannot be in the form of this one. But if you find the picture where you can easily differentiate the butterfly pattern, we can say it's a butterfly rash, is very much common in SLE condition. And of course, if it's there with the scenario thing, the question is there with you, then you can see the ANA level, you can see the criteria of the diagnostic SLE, and then you can easily differentiate, okay, this is a SLE rash, it's a butterfly rash. Vitiligo, here also we will see there is a pigment deficiency. It's, of course, here we are seeing it can be started with a very small patch, and it can cover the whole face, neck, hands, all over the body can be covered with this one. Here you will see it's a pigmentation disorder. But how you're going to this, especially this one from the melanoma. Melanoma, of course, is a cancer thing. You will always find this melanocyte overproduction in any one particular side where the cancer is there. You cannot find melanoma in the whole body, but this vitiligo portion, we will see the pigment deficiency in some part of the areas that is clean white, and the black one showing too much amount of melanocyte there. But of course, that is not in that much amount. There you can say it's a melanoma. It's not a melanoma. It's just a high pigmentation area, and the low pigmentation area, then we can say it's a vitiligo. So usually for the vitiligo pictures, you will have a broad picture in front of you, and you can easily differentiate. Okay, it's in the form of patches, or maybe it's in the form of regular continuity, maybe in the form of patches over the skin, somewhere hands and face and neck and body. So you can easily relate with the normal person. What's very common presentation, very common question in exam they usually asking, and they usually giving you the pictures of hands, especially the palmar surface. So we know very well it's caused by human papillomavirus. It can occur all over the body. Usually the warts, once started, they are very itchy one, but once they become mature, sometimes they will not do anything. They will just be like there. And then what you need to do, once you're wearing shoes or you're doing hands activities, then you actually keep on bothering because of their pressure effects. Then what we will do, we want to get rid of them. We can use just some simple cryotherapy. We can always offer for these one, or we have some of the bandages, pressure bandages that can easily remove the cap of these warts. So we can remove them. But of course, it's a human papillomavirus infection, and we can find anywhere in the body, but mostly they are found in the areas like the palm of the skin, palm of the hand, and the inner surface of this 1 feet. You can find them, but of course it can be anywhere in the body. Usually they are solitary, but multiple also can be there. So it depends on patient to patient. So good hygiene is very much recommended here. Plus, we can always go for the treatment option. Of course, we can just get rid of this. Initially, they are very itchy, but later on they will become only giving the pressure effects. Later on, they are not going to bother you. Just only the pressure effects are there. That's why we want to get rid of them. Now, very important, you two pictures, chickenpox and measles. You should differentiate between these two pictures. Although chickenpox you can easily differentiate because these are the clear water-filled vesicles, blisters you can easily form. But what happened once in the later stages, once these blisters are deformed, they are going to rupture, then the appearance is quite become difficult for, especially for the junior doctors, to discriminate this from the measles. So look at the pictures again and again, especially in comparing this chickenpox with the measles, so that you can get a clue. Okay, of course, clue that of course in chickenpox you have this blisters, fluid vesicles that can occur mostly starting at the back of the chest, and of course it can be there. It's once the chickenpox started, you cannot find too much amount of blisters in one area. That's a very common presentation. You will find these vesicles, blisters, filled vesicles, but apart. Say if you can just appreciate this one. Here they are actually apart from each other. I'll show you the picture of measles later in the slides, but just have a look here. They are not very much together in a form of clusters, like in the form of ringworm infection. If you could just appreciate ringworm are all together and they're forming the one ring. Here you will all find these blisters, but they are very away, especially away from each other, and they are fluid filled. Thing. And of course, if the scenario is there, you can easily relate with especially if there's contagious disease. Of course, it's very common in the children. That's why we are offering this vaccination also in order to prevent. And mostly this only in low socioeconomic status you will find this chickenpox problem. Otherwise, in first world countries, you will never ever find this disease. Okay, this one is very common, for exam point of view. They usually give this diagram where you can find easily this bumping portion in the skin. So that is called ganglion. So ganglion, these are actually the lumps. They are the cysts. They most commonly occur in the wrist, and you can easily, of course, they are the lumps, but they are non-cancerous. And they are not like lipoma. Lipoma, if you could recall lipoma can easily fluctuate. It's just like a subcutaneous fatty tumor which can easily rotate from one place to another place. But ganglion cyst is not like that. Ganglion cyst is very much adherent. See, if you could just see, it's coming from, they are showing you it's coming from the bone like this. So they are very hard structure. You cannot move them, especially these ganglion. They are going to be fixed, and once you move, you will feel that they are attached to the bones. It's giving you the firm appearance like that. Of course, these are the non-cancerous ones. They can occur anywhere, but the most common presentation you will always find on wrist. So if you could find any picture where this bumpy thing is there on the hand, especially on the wrist, always make a diagnosis of this ganglion. And if you could just see 2-3 pictures of ganglion, of course, you can easily differentiate. Now, these are the measles. Now, if you could just compare this measles with the previous chickenpox, so you can easily differentiate in the chickenpox, they are the blisters, they are very far away from each other as compared to the measles. This is the back of a small child. You can easily see. And measles, of course, the presentation is always like you can always differentiate. The 3 C's are there, cough, coryza, and conjunctivitis. Very high fever are there. Rashes are very important, and especially on the buccal mucosa, if you could see on the second upper molar tooth, you can find cop-like spots, white spots are there. So there is much more diagnosis for measles, but of course you can easily differentiate. These rashes are very much different from chickenpox blisters. These are also very small macules and papules, but they are very close to each other. They're giving you just appearance that they're in a clustered form, and you will not find blisters and fluid-filled vesicles here. But they are very numerous in number, and you will find all over the back of the baby. This measles is going to be filled. Okay, melasma pictures are also very common. Melasma pictures is, yes, Dr. Taira.
What you told us, what was coryza?
Coryza is the nasal mucosal inflammation. If the nasal mucosa is inflamed, you can say it's coryza. So because of too much watery running nose, the nasal mucosa is also getting stuffed. So too much running nose is rhinorrhea. So rhinorrhea is mostly associated with coryza, like nasal mucosal inflammation.
Okay.
This melasma, Melasma, usually you will always find typical presentation of a scenario of PCOS women, if you could just recall, like in polycystic ovarian syndrome and those who are very obese patient, you will always find these insulin resistant patches. Mostly melasma, we are saying that these are the freckles or gray patches or brown patches, but they are very much related to obesity. Similarly, these melasma you can find in the children also who are very obese, and especially in their creases, like in the neck crease and in the shoulder joint. If you could just see in the axillary region or in the elbow region where are the creases, so those creases are very getting very darker. So dark black lines over the neck, dark black lines over the elbow joint, and especially these freckles in the form of freckles that you can find over the skin, over the cheeks. So they are the melasma. So melasma always, if they are giving you a scenario something related to PCOS and the picture is there, it's very much common. The melasma is there. Or if the scenario of any obese patient is there, you can always think about melasma. Melasma is mostly associated with obesity. But you will find these freckles, these only in the superficial part of the skin, you will find this brown appearance. And it's very common in women over 30 years of age. You can easily find melasma in every woman. Some part is there here and here, like small patches of below the eyes, below, over the cheeks, maybe in the elbow region, you can easily find. And neck is the very obvious thing where you can easily locate them. In hypothyroid patient, in diabetic patient, you can easily find melasma. Okay, so impetigo, again, this is very important. You have to differentiate this honey colored colored crusted lesions with the seborrheic dermatitis. If I could just take you back and showing you this seborrheic dermatitis, see these are also honey colored, right? But their pattern is they are the sebaceous glands who are having this problem. They are producing too much sweat. The accumulation is there in the form of dandruff, and they are appearing as this one, seborrheic dermatitis. But if you are coming here in impetigo, you will see it's not a sebaceous gland overproduction. It's actually a bacterial infection. So it's very much worse as compared to the seborrheic dermatitis. When you look over again and again the pictures of seborrheic dermatitis and impetigo, you can easily differentiate that these are also the honey colored lesions, but they're very much extensive. They're very much extensive, and you can find them very much, they are very topped up. They are not over the if you could evaluate here, their redness you can see somewhat here and somewhat here, and then the crust is there. So it means that there is some underlying going on, inflammation and infection is there. So that you can easily relate, okay, this is impetigo and this is seborrheic dermatitis, because you can relate these two together because both of them are usually presented with honey crusted lesion. But impetigo is very much crusted, topped up lesion because there is underlying inflammation and infection is going on. Whether in seborrheic dermatitis, it could be a flat one, and it's just like a dandruff who is going to wipe off from the skin and having the colored.
Excuse me, Dr. Hira.
Yes, Dr. Tyra, I cannot hear you.
Yeah, sorry, I cannot hear you. Achha, okay, this seborrheic dermatitis is found on the head of the babies, and this impetigo is found in the mouth, face and mouth area, around the mouth. Excuse me? Can you hear me?
1 minute. I think there was some problem with the net. And
Dr. Hira, you're not audible.
Yeah, 1 minute there. Okay, now can you see the picture?
Yes, we can see.
Okay. So there was some, I think, problem with the net. It was disconnected. Okay. So see, for seborrheic dermatitis, the most presentation is a scalp, and when it's occurring in the babies,
So I was trying to
yeah.
I was trying to differentiate between these. The seborrheic dermatitis is found usually on the scalp of the infants. And the
Babies
impetigo
mostly.
is found in the toddler's face and the mouth around this in the 1-2 years old.
Exactly, because it's a skin infection. So it's a skin infection you can find anywhere in the skin. But seborrheic dermatitis you will usually find where the sebaceous gland are more in number. So sebaceous gland are more in always in scalp, right? There are too much amount of numbers of sebaceous gland in scalp. That's why that's most occurring in the scalp region. While this impetigo, it can be anywhere on the skin because it's a skin infection. Got the point? And it and once yes. Okay. So now going to the next one. Now ringworm infection.
Dr. Hira, we are not doing their treatments.
No, treatment you will do in the theory. Here we will only cover the most important pictures, like pictures what can come in the exam. Treatment you can do by your own. If in fact most of them we have covered. Impetigo you can go it by yourself. Otherwise we will be late. We have to cover a lot here. So here I'm just going to show you the most common images which they usually ask in the exam so that you can go them over again and again and memorize them, like how you are going to differentiate with the other similar presentations. Okay. Now we are coming to this one, ringworm. So here you can find multiple ringworm infections are there. Let me just check my internet. 1 minute there. I think I should connect to other network. I'm going to share my screen again. Okay. Can you see my screen?
Yes.
Thank you. I just changed the network. Okay, so here you can see ringworm. You can find it solitary also, one single ringworm infection, a big one on the skin or big one over the neck, behind the neck. But here in this picture, you are going to see more, multiple rings are there. And of course, it's one of a fungal infection. It's shaped like a ring. That's why it's called ringworm infection. And anyone can get this one. It's not about this one. It's actually based on some hygienic conditions or non-hygienic condition. Of course, it's a fungal infection. It based on some body pathophysiology as well. Say, for example, those who are having too much sweat secretions and they are having some skin problems, recurrent skin infections or recurrent allergies, those who are having, they can easily get this ringworm infection. If it's endemic in some area, of course, that also that you're going to see. So just look at the pictures here that you will find some ring appearance. It can be a solitary, like only one you can find anywhere or like on the over the skin, especially on the dorsal side of the skin, or maybe you can find it in a collection way. This keloid we have already covered in the theory. It's because of the piercing of the skin. Say, for example, for this women, the ear must be pierced, right? Because of the cosmetic purpose. And then see later on what is happening here. The keloid was there. It's a raised scar actually. We have already covered this in theory, but look for the different pictures of the keloid, like where you can find over the surgical scar also you can find keloid. But mostly they are giving the picture of especially ear piercing or where the jewelry or ornaments are pierced. That area actually showing you some hyperactivity, hypertrophy, and this tumor activity called keloid. Okay, acne is very common. For acne, they can give you any picture, but most likely you are going to see adolescent pictures because they are very much common in adolescent age. And what is actually happening here in acne? These are the hair follicles. They are going to be plucked up with oil is there and skin is there. So mostly those men and women who are having this oily skin, they can present with this topped up lesions, these blackheads, this whiteheads or pimples. We can say usually in normal term. In teenagers, they are very important. They are very common, and we have to go for acne treatment. Of course, it's available, and mostly we have to do vitamin A supplements to these patients. And why we are giving this one? In order to reduce this too much overactivity of this oil formation, especially over the face and where this appendicular facial glands are involved, in order to inhibit the production of those glandular secretions. That's our main goal. But anyhow, you can find anywhere in ages, but mostly you will find in adolescents, and there will be pimples all over the face, widely spread. So you can easily differentiate it as acne. So acne is very important as far as their diagnosis and their symptoms for their question point of view. But they can give you a diagram also, picture also, so that you can easily get a clue. Okay, this is the facial acne, which is very much common. but it can be happening anywhere in the body. Okay, this this aphthous ulcers we have already covered in the theory as well. You can find multiple also, but most of the time they're usually the single one. Mostly you can find them inside the lower lip. You can see this is the lower lip. Inside the lower lip you can easily find, and of course it's ulcerative condition. It's very painful. Our patient is having, most of the time the patients are having the stomatitis. They're having pharyngitis in common again. So maybe in some viral infection, you will also find in pharyngitis also. And whenever there is any oral cavity infection, you can also find this aphthous ulcers. But usually they are white-based, topped up lesions. You can always find them inside the under the lower lip.
What are their etiology? What are the reason animal organism?
These are these are can be because of virus. Most of the time these are because of the virus, but sometimes these are because of the use of too much excessive of the spices. Say for example, those who are eating too much spicy food, those spicy food can also irritate the mucosa, and they can be there. But actually these are the infectious one. Mostly they can cause by any hand, mouth and foot virus. You remember that virus that can cause any hand, mouth, and foot disease. But sometimes those who are deficient in vitamin B12, sometimes those who are deficient in folate, deficient in too much iron deficiencies there, then also you can say these people can get this aphthous ulcers. Most of the time, etiology is unknown, but the viruses can also, the virus especially the one who can cause hand. Treatment mostly we have to give some ointment for just if there too much infection is there or pain is there, we have to give some local sort of anesthetic gel you can give. Other than that, they are not infectious ones, so you're not going to give antibiotic to these one. So only the gel, so that the patient who's eating anything, that is not going to attach with that one, that's not going to interact with that one or react with the food. So just in order to prevent, we can give some gel, and that gel is going to actually separated from the food content. Our main thing is that. And anyhow, it can be revealed. If you give the vitamin B supplements, you can provide folate supplements to your patient, it usually heals away. So you don't need to give any proper antibiotic or something, just a supportive treatment. And vitamin B12 is highly recommended in these patients.
Vitamin B12, huh?
Vitamin B12, yes. Okay. So you may also find some ophthalmoscopic pictures also in your exam. So you should cover some ophthalmoscopic pictures, especially whenever it comes to diabetic retinopathy, whenever it comes to diabetic maculopathy, whenever it comes to retinal detachment. So you should know, you should be able to diagnose that these are the ophthalmologic findings. So maybe this is this one. Say for example, here you can see this is diabetic maculopathy. So what you're going to see here, when you put the ophthalmoscope, you can see the retina of the diabetic patient showing retinal maculopathy. And what are this thing? First of all, you will always find this orange image, and you will find this area, which is called the optic disc area, as a yellow. See, there will be a yellow optic disc, yellow projection. So if you could appreciate these vessels are coming from this area. So yellow patches are seen around the retina caused by leaking of blood vessels. So all the blood vessels are coming from this area especially, and they're going to supply the whole retina. So these are the special findings in maculopathy. What we are going to see here, you are going to see these yellow patches, especially some yellow patches you can also appreciate here as well. Dark spots you can also find here. These are the dead cells due to inadequate blood supply. Ischemia. So if there is ischemia of the eye because of long-standing diabetes, that will give this appearance to the eye or this appearance of the retina. So it's not happening in a year or so. It will take some time. That's why this for retinopathy, this screening is very important. And you remember the screening point of view. For those who are having type 1 diabetes, you will start this screening after 5 years. And then you will do annually. And those who are having type 2 diabetes, you will start this screening as soon as you diagnose the type 2 diabetes. Just send the patient right away to the ophthalmologist for the screening part, and then every yearly you will ask the patient to go for this screening. Why? Because we don't want these maculopathies and retinopathies to be developed, and this is showing ischemia of the retina. The diabetic retinopathy is caused by damage to the blood supply of the retina, of course, that occurs as a complication of diabetes. And these yellow patches, which you're going to see here, these are the hard exudates which leak from the blood vessel, and they have become permeable due to diabetes. And these exudates can cause irreversible vision loss. So once the vision loss is there, you cannot revert that thing. That's why the screening in diabetic patient is very, very important, because once they lose their visual power, there is nothing, that can revert that thing, because that's ischemia, and prolonged ischemia is giving the hardened thing, and the necrosis will be there, and the whole retina will be damaged. So if in any ophthalmoscopic pictures you will find these dark spots, you will find this yellowish optic disc area from where the blood vessels are protruding, and you will find this the yellowish hard exudates, especially over the lower surface just beneath the optic disc. You can easily correlate this as a diabetic maculopathy ophthalmoscopic findings. Now, this one is macular degeneration. Macular degeneration, here we'll see changes in the retinal pigment. If you could just appreciate, it's not a yellowish one. It's not all over orange one. It should be a typical orange if it's a normal retina. But if appearance is not becoming orangish, but it's rather than it's becoming blackish and yellowish, and with the small yellow transmitted all over the retina, it's called drusen sign. So drusen is very much appreciative. If you find this drusen area, which is a black area surrounded by this all yellow patches, so that is a clue for you in making a diagnosis of macular degeneration. Again, the same thing.
Excuse me, how many?
Macular degeneration occurs in diabetic maculopathy?
Yes, in diabetic maculopathy, it's in combination also, and alone also it can also occur whenever there is retinal damage. That also you can see, especially in all the renal compromise, the patients who are renal compromised, in those patients you can also see this one. So the very important point for this macular degeneration, which you're going to remember here, is this yellowish deposits. These all cellular deposits that accumulate under the retina. These deposits are called drusen. So drusen, whenever these drusen are there, and they are very much, if you could just appreciate with this one, here you can find a little one. But if we are saying macular degeneration, the word degeneration, it means that all over the retina, you will find this degeneration. And it's very common in old people. So you will never ever find this macular degeneration in 40 years or 50 years. Mostly the patient must be above 60 years of age whenever you see, and mostly females are much more involved as compared to males. So this is a very, very important thing. So these drusen must remember whenever in the question also drusen mentioned, and you will find something like this one. You can appreciate too many drusens, too many debris, yellow debris, hard exudate tissues there. And in between the blackish areas there, it's shown gene degeneration. You can think about macular degeneration. So in diabetic scenarios as well, in any kind of renal compromise, and those are immunocompromised also, you can find these problems, but mostly linked with diabetes.
Excuse me, Dr. Hira, can we compare between these two pictures, this one and the previous one?
Yeah, sure. See, this one you find this more orangish, right? You cannot appreciate any kind of blackish area in center, right? But here, if you could appreciate too much dark area is there. Like this orange is a very bright orange color, right? Bright orange. But if you could just compare this one, this is very dull orange, or I should say it's a blackish orange, right? It's a very dark shade of orange. So it's showing degeneration. Here it's not, there is no degeneration. Yes. Only these hard exudates are here, and a little bit degeneration is here. But here you can appreciate too much degeneration. The blackish portion is showing necrosis also. There's too much deposition here, although new vascularization is there. New vessels are forming here. That's a phenomena of retinopathy. Whenever there is retinopathy, it's our vessels which are defensive, and they are going to reproduce. So new vascularization you will always find. But there is no point of these all new vessels, because once the damage is there, because you have already learned this one. When ischemia is there and ischemia is converted into irreversible one, necrosis is permanent. You cannot change the necrosis. Even if you do the new vascularization here, what will happen? It again going to damage the area again more and more. It's not going to recure this one. So don't confuse with this new vascularization. It must be there. But look at the debris, look at the degeneration part. You can find here a lot. And especially if you find this lucency. So this lucency is very bright, and this lucency is very dark. So you can easily differentiate. Right? And there must be some blackish area you can easily differentiate. That must be showing necrosis of the retina. this one. If you compare all these two and now this one. So what you can find here, there are too much neovascularization. Many vessels are forming here, and there is no as such damage here, right? There is no as such damage. You cannot appreciate any blackish area here and all that. So there is actually insufficient retinal perfusion results in the production of vascular endothelial growth factor, and those growth factors are doing much more formation of new vessels. So you will see the phenomenon of neovascularization, like new vessels are going to form here, but it's still, this is insufficient retinal perfusion. It's still in the phase of ischemia. It's not crossing the state of reversible ischemia. It's not coming under the heading of irreversible. They are not showing necrosis at all. They are just at the beginning of less perfusion. So there you will find no damage in the sense there is no degeneration of the cells you are going to see here, and you will see much more vessels formation here. So this is called proliferative diabetic retinopathy. Whenever it says PDR, proliferative diabetic retinopathy, it's just the start of the ischemia. Like just as soon as the ischemia started, as soon as the eyes are getting involved because of long-standing diabetes, the first thing you are going to observe in your patient is this slide, and then you will observe this slide, and then you will observe this slide. So these are the stages. Of course, they can be an other condition as well. Say, for example, macular degeneration, but for your clinical point of view, if I'm considering, so one, say, for example, the patient who was having long-standing diabetes, say, for example, for the last 20 years or for the last 25 years, he was having diabetes. And once his eyes are going to involve, then first the first ophthalmologist will find this kind of picture, then he will become alert. Now, there's an alarming point for the ophthalmologist that why this neovascularization is happening, because your eyes are getting compromised. It means that maybe you're hypertensive, maybe your LDL levels are not controlled, maybe your sugars are not controlled. That's why you're having this problem. And now you have to be very strict on your diet, and you have to be very strict on if you're taking insulin or whatever is there, your glucose level should be perfect in your body, so that this will not lead to this one where the degeneration started, and this one finally it cannot lead to this one. So in order to prevent all these stages, the ophthalmologist should be very alert, and the doctor, of course, whoever is treating the diabetic patient, like they will say to you, and they will say to the patient that now it's an alarming sign in your eyes that proliferation is started, which is showing that your retina are having ischemia. And if this ischemia goes into an irreversible, reversible one, so later on we will find some degeneration, and lastly we'll find all over degeneration. So these are considered to be the stages. But of course, for your exam point of view, you will find only one image, so that you can just on the basis of that, you can easily differentiate that what kind of stages this one. Okay, so for some X-rays, very common presentation of this boot-shaped appearance on chest X-ray. If you can easily differentiate on the chest X-ray, remember that's a congenital one, that is called tracheology of Fallot. So this stuff is very much common, and you can easily differentiate on the basis of this boot-shaped heart appearance. And we have already covered this in theory, so we are not going to much details about this one. Now this one. Second, we have this pneumothorax. So if you could just see the normal structure of the X-ray, what you can easily say, whenever there is black thing you can see here inside, that will always show you the air. So now if you could differentiate here the slight whitish thing is here, you can easily differentiate. The black portion is less, and you can easily see white things here. You can see the pulmonary markings as well. But here, if you can appreciate, there is too much darkening here. So if you can find anechoic area in chest X-ray, we should always say anechoic in ultrasound. But just why I'm saying anechoic, because anechoic means that it has nothing inside. It's a purely black thing. So whenever in chest X-ray, if you see a purely black shadow, it always indicates that some air is actually trapped here, and this air is not getting out from this area. So if the air is getting trapped here, you will say it's a pneumothorax. So pneumo means air is actually trapped inside the lungs and it's not going to get out. Why? Because there is damage to the alveoli and the air is actually leaked into the alveolar spaces. That's why it's not getting back into the bronchial tree again. So whenever in the chest X-ray, if you can find this blackish area, then you can say it's a pneumothorax. And what if both of these lungs are pure black? I will show you some in the next slide as well. Say for example here if you could just see the whole thing is black, then what you will think, what is happening here? Of course it's a pneumothorax here, and one side is all filled with fluid. All fluid can be anything, it can be blood also. So if the fluid is there, you will always say it's a, you will always find on X-ray white thing. So if the blood is accumulated in the cavity, you will always find that blood in the form of white thing, white shadow on the chest X-ray. And if too much air is there, you will say it's a too much black thing, you are going to see it's air. So half of the lung is filled with blood and half of the lung is filled with air. This is mostly happening in those patients who are having atelectasis. And this atelectasis are usually occurring soon after surgery. Soon after surgery is the patients, because the patients are usually bedridden, they are not getting up. And if those patients are already having some respiratory compromise, they are getting prone to this thing, like their air is also trapped in the lungs, and the water secretions and blood secretions can also trap in the lung. At that time, we can say it's atelectasis. So you will always see too much blackening. So if we will cover this later if we come back here. So you can differentiate here. This part is normal, this part is normal. You can easily relate this one. These markings are visible, but this area, a small portion of this area is showing what is showing highly pneumothorax, and especially we'll say this is the right side, this is the left side. So right lung is having this pneumothorax. This atelectasis of the lung is here, especially on the lower zone you will find. And rest of the thing, if you can say, so of course as compared to this one and as compared to this one, there is too much whitening as compared to this. It means that there is some fluid collection also here. And do you think the heart and the mediastinum is in the middle? Of course it's not in the middle, it's little bit shifted here, but here we are not considering about this one, because you need to do the spot diagnosis, and the spot diagnosis is pneumothorax, where we can see here. Now here also you can differentiate. Here also too much. Yes, dear.
How you were making this same at one picture, pneumothorax and atelectasis?
See, because atelectasis, I will say whenever there is a history of post-op condition, then we can say, okay, atelectasis is there. But once someone is going to ask you what are actually the findings, you will say this is too much air is trapped here. So this most likely indicates a pneumothorax. Now you will inquire, because pneumothorax is always related to thoracic trauma injury. Now again, you have to go for the clinical history. You cannot say in some patient, without knowing the history, that this patient is a case of pneumothorax, because we know very well the etiology of the pneumothorax is always a trauma to the chest.
No, in the previous slide you were saying is this one. You were saying
because here why I am saying atelectasis, because atelectasis is a general term which means air inside the lungs. That's a normal term. But this term is highly associated when there is immobility of the patient, whenever the patient is having a history of some post-operative history, some major operation has done, the patient was not on intensive spirometry, the patient was having some previous respiratory infections, means some respiratory compromise was there in the patient, and the patient has undergone a massive surgery, and now the patient is immobile, and you didn't start spirometry yet in your patient. Those patients are more prone towards having this atelectasis. So that is only the thing when you have some clinical diagnosis in your hand, like some history should be there. Then you can.
No, Dr. Hira, see, pneumothorax is where there is air trap in the lungs. Okay, it will be the result of injury to the chest and lungs. But atelectasis, you are saying after the surgery. But after surgery, there will be might be infection, but there will not be any injury to the lungs.
See, Dr. Tyra, first clear with the term of atelectasis. What do we mean by atelectasis? Atelectasis means that it is actually maybe a complete or maybe a partial collapse of the lung. So here the lungs are actually going to get collapsed. And why they are going to get collapsed? The main etiology is this one, like they are having alveolar spaces, they are having alveolar sacs, right? So within the lung, what happened when these alveolar spaces when these alveoli are deflated, possibly most likely with alveolar fluid. Most of the time there are the alveolar fluid, and sometimes you will not find anything. then we can say it's atelectasis. So atelectasis is a collapse of the lung. So why I'm saying this, especially this atelectasis here, why I'm saying this one, because again air trapment is here, and some of the white portion you can see here means some of the fluid maybe is here. That's why it's giving a shadow of white thing, and it's much more appreciable here as well. Too much is here. So just forget about this atelectasis, because atelectasis is not this picture. Atelectasis is purely this one, when one is whole side is filled with fluid and one whole side is filled with air. This is a pure atelectasis. Here I can just relate with this one with pneumothorax, I can say, but if you are purely asking for the atelectasis, this is the clear picture of atelectasis, where right hemithorax and the left hemithorax. The right hemithorax is going to show you hemithorax, like blood is there, and on the left side you will see a totally trapment of air. This is a pure picture of atelectasis. This usually happened post-operatively when this side of the lungs is totally having trapped air. So this is collapsed because of the air, and this is collapsed because of the blood. So that is the typical presentation of pure atelectasis. Here also the collapse is here, because here also the air is trapped here. That's why we just say it's atelectasis. But in usual term, whenever there's a thoracic trauma history and you will find this thing, you will not say atelectasis here. You will always say pneumothorax, because pneumothorax means that there in history there must be a trauma to the patient, history to the trauma to the chest wall, and then the patient is having collapsed lung and showing this thing. Then you can say it's a pneumothorax. You got my point? So don't confuse yourself, because in pure atelectasis, whenever you have a X-ray, this one will get.
Excuse me, here in this diagram, how this patient will be alive? If his one lung is filled with lung is collapsed and other is filled with fluid.
We will, with this in this atelectasis picture, you are saying this one.
Yeah.
Okay. In this one, we will put our patient on spirometry. Have you ever seen post-op patients? They're having this device where they need to they need to blow the air, and they need to pump these balls. There are certain balls in the device, and they need to blow they need to pump or blow the air in that pipe, and that pipe is going to push the balls. So we usually ask a patient to hard do the expiration, forceful expiration. So when they do the forceful expiration, soon after surgery, what will happen, because of the anesthesia effect, that anesthesia effect also going to get better, and this air also is going to get distributed, and this blood also going to absorb again in the interstitial spaces. That is how this patient
that only is called spirometry.
Yeah, it's spirometry.
So spirometry is the study of the lungs functions, now.
Spirometry is the study as well, but this is the main exercise for the patients who just now operated and they have already been this respiratory compromise. You will ask your patient to do this forceful expiration again and again. They are doing this exercise 4-5 times, and occupational this therapist has to come and do this one. Especially this therapist has to come for this exercise for these patients. And they usually ask the patient, and they ask the patient to do in front of them, and once the patient is doing again.
I have seen my brother was admitted in the hospital last year with COVID. So he was asked to do this, and I had
so that is one of the very good exercise for the lungs, because by doing this thing, by doing forceful inspiration and expiration, they are actually removing the accumulated air traps, and they are removing this one, the fluid from the lungs. So that is the very, very good exercise for the lungs.
Okay, yes. Okay. That is called spirometry, yeah?
Spirometry, yes. Okay. Now here, if we see this X-ray,
also the test we are doing for the lungs, there also spirometry.
So that is a diagnostic test in normal lungs. Whenever you are going to diagnose for any kind of lung pathology, that is also a spirometry. But here, that technique we are using for relieving the patient. So that is diagnostic plus therapeutic as well. Yes. Okay, for pleural effusion, if you want to diagnose a pleural effusion, you can easily see on X-ray there is too much whitening. So if there is too much whitening here, it means that there is some kind of effusion here. Maybe fluid is trapped here. Most likely the fluid is there, or sometimes blood can also be there. So you need to differentiate on the basis of history. Now, what is there? You can easily see too much whitening, and you cannot differentiate where is this mediastinum, where are the angles and the borders of the heart. You cannot differentiate that. So if too much whitening is there, and because of that, the half of the lung is all covered, you cannot differentiate the diaphragm, you cannot differentiate the borders of the heart, then you can say it's a pleural effusion. This one. This one is this one. They are saying it's a tension pneumothorax. If you could just recall the tension pneumothorax from your theory, then you must know in tension pneumothorax there always it's okay. There must be a traumatic history as well, but there always a shift of mediastinum. I think you could recall this one because just now we have covered this theory. So for tension pneumothorax, always there should be a shift in the mediastinum. Now, if you could just appreciate here, can you imagine? Can you appreciate this one? This one is right side. This one is left side. Can you appreciate this whole thing is shifting towards this side? Now this portion is very less. This portion is too much. Now you can easily see the whole mediastinum is shifted to the left, and trachea also is going to deviate on the opposite side. So if X-ray is showing too much mediastinal shift on the opposite side, why I'm saying on the opposite side? Because I can clearly see there is too much air is trapped here. So this is pneumothorax, and because of too much trapment of the air here, if this air is capable of shifting the whole mediastinum to the opposite side, we can say it's a tension pneumothorax. So whenever there's a tension pneumothorax, because of the too much trapment of air, this air is now capable of pushing the whole thing of this middle thing to the opposite side. We can say it's a tension pneumothorax. So you can easily differentiate. Just check the diameter. This hard shadow should be in the between, but it's not in the between. It's all shifted to the left side. So we can say it's a tension pneumothorax.
Dr. Hira, please show us the markings of mediastinum here.
See, mediastinum is this one. Diaphragm starting from this one. Now here it's pleural effusion as well, but I can still see this is the left border of the heart, and then I can still see diaphragm is here, right? So diaphragm here. This is called mediastinum. Mediastinum is the space between the two lungs. So this is all mediastinum, but the markings are like this one. Heart is like this. Heart is not purely visible because of the pleural effusion, and this diaphragm all here. So this is called the marking.
No, mediastinum is not down here. Mediastinum is up.
Mediastinum means the space between two lungs. So this one and this one. So this lung, can you see the cavity is too much small here, and this cavity is too much big here?
You will usually be considered at the upper half of the lungs.
Of course, because the space between the two lungs. So the lungs start from here till here. So whatever the space in between, from here to here, in between these two lungs is called mediastinum, and heart is in the mediastinum. Of course, and diaphragm is also in the middle, and diaphragm is also half here and half here, and in between is a mediastinum. Mediastinum is a space between the two lungs. So of course, all this portion, that's why we are saying the whole mediastinum is shifted to this side, right? And there is this lung cavity is so small and this lung cavity is so big because of the too much air which is trapped in here because of trauma.
Tracheal deviation.
Tracheal deviation. We can also appreciate here. See, tracheal deviation line is purely visible here. Okay. This one. Now for this one, if you could appreciate this diagram, what we can see here, too much air is here. That's why it's showing too much black area. So if you could see this too much blackening here, we can say it's emphysema. So what do we mean by emphysema? Emphysema, yeah, the alveoli, the lung tissues, everything are destroyed, and all the damage is there. And this alveoli cannot support the bronchial tubes, and there's a too much tube collapse occurring here because of the blockage and because of the obstruction. That is called especially emphysema. That's the typical presentation of barrel chest appearance. So it's too much. You are going to see the alveoli and lung tissue all destroyed here, and air of course is all trapped here. That's why giving a shadow of this darkly black shadow. So that is all emphysema. Okay. Now for this one, consolidation. So see, first of all, we should know what is consolidation. Consolidation means that it refers to the alveolar air spaces being filled with fluid. Fluid can be anything, can be an exudate, can be a transudate, can be a blood, right? So if we can see the air spaces, especially the alveolar spaces, if they are going to fill with blood, or we should not say blood, we should say fluid, because fluid can be anything. And cells and tissue and all other materials are also filled with this one, then that is consolidation. Now, if you could appreciate, whenever I say that the thing is filled, the lungs or alveolar spaces are filled with fluid, I must show this in a diagram with the help of this white marking. So if you could see white area, all over white area, it should not be white, it should be black here. because it should contain air, because lungs should have airs, not the fluid. But if the lungs is showing you this whitish, slight whitish area, it's showing that this is actually filled with fluid. Then we can say these are the consolidation sign. Consolidation sign means that the alveolar spaces are going to fill with fluid. And there may be many reasons why it's happening. The first reason is pneumonia. In pneumonia, you will always find this consolidation. All right.
Okay.
Now, tuberculosis, for tuberculosis, I need to take you to one side, because tuberculosis chest x-rays are very, very different in it, in presentation, because the start of the tuberculosis, the middle and the end of the tuberculosis will always show us some different pattern. Like in the start, you will always find some lymphadenopathy. So I should take you to this website. There you can find most of the things. So just let me know if you can see my screen. Can you see my screen?
Yes.
Okay. So see, this is the first pattern. This is the first picture of tuberculosis. That's called the primary pattern in tuberculosis, where you can easily differentiate lymphadenopathy. Lymphadenopathy, here in the X-ray, if you can see mainly in the hilar region, if you can find this one, this whitish area, especially in the hilar region. Hilar region is this hilum part. We usually say in between the lungs, in the center of the lungs, we have this hilum portion from where the vessels are coming in, coming out. If this area is showing whitish area, that is called hilar enlargement. So here we can easily see this is the right hilar enlargement. So if you could appreciate this right hilar enlargement, that is the start of the initiation of this tuberculosis. That shows lymphadenopathy. So it can be there on X-ray. So if tuberculosis X-ray is there, and you can easily look here that in the hilar region there is whitening area which is showing the hilar enlargement, that can also be a chest X-ray showing early stages of tuberculosis, showing lymphadenopathy in tuberculosis. That is the primary pattern we will see. Similarly, in the next diagram, you can see this is also the primary pattern. Here also we can see lymphadenopathy in the hilar region, because this is a small child, but you can still appreciate the white patches here. So this white patch is also again going to show you the hilar enlargement, and there again also a lymphadenopathy. This is a 5-year-old boy. It's showing which side of lymphadenopathy. This is the left side. So this is left hilar enlargement. So we can also say it's a tuberculosis because it's showing lymphadenopathy. Here you can see consolidation. Now here you are not going to see the lymphadenopathy. Here you see these small white patches all over here. It's showing some fluid collection here. This fluid can be of exudate, this can be a transudate, this can be a blood as well. Most likely it's a transudate one when we are considering tuberculosis. So if you're considering this one, this is a 12-year-old child. So this collection of white fluid which is appeared here as a white collection, it's a consolidation. So maybe you can see lymphadenopathy in some X-rays, maybe you can see this consolidation. It can also pointing you towards. So of course in this scenario there must be a history of, there must be something which is always pointing you towards that this patient is having tuberculosis. So for example, he must be having the TB close contact, or he's already on ATT, or he's having symptoms of TB. So you can easily relate with the X-ray. Okay, this is the X-ray showing consolidation. So this must be the TB patient. Now here you can see tuberculoma. So lymphadenopathy, then you have seen consolidation, and now here you can see this tuberculoma. This tuberculoma is a particular cavitatory lesion. Especially we are going to see where these lymphoid organs, they are going to attach with this one, and they are going to do some lymphoid reactions is going to happen here. Granuloma formation will take place, and thereby it's forming a tuberculoma. So you can, if you can appreciate tuberculoma, which are mostly, it's not always there. This tuberculoma here you can see in the CT, it's tuberculoma. You will find in the upper zone of the lungs, but the most common presentation, maybe you can find anywhere else in the body, but most likely you can find in the upper portion. Okay. So lymphadenopathy, starting with the lymphadenopathy, and now here, so this is the most obvious state where we have seen the infection has already progressed so much, then it's going to form this tuberculoma formation. Starting with the lymphadenopathy, in the middle you can find consolidation, and later stages you will find tuberculoma. Now these again you can find
Hira, in the previous picture, the vascular markings were very
very
pronounced.
prominent here. Yeah, yeah. A part of this one we have, this is a prominent feature. Yeah, pulmonary, because of course whenever there's a pathology condition in that, we have to rule out other things as well. If there is any, you will find if there is anything with related to the pulmonary hypertension, if the known hypertensive is there, then you can find this increased pulmonary markings. So of course that is not the big deal here. Here the big deal is that we are staging the tuberculosis. Yes. Okay, here you will find this cavitatory lesion. See if you could find the cavity filled. It's just like a whitish portion having some black inside. So it's particularly a cavity. If here it's quite visible, if you could see here, it's a purely cavitatory lesion. So cavitatory lesion again, it's indicative of tuberculosis. This is one of the immunocompromised patients. It's showing in this infection. So it's going to proceed one by one. Say, for example, in consolidation, mostly we can find this cavitation and then tuberculoma. Most likely cavitation is occurring prior to tuberculoma, but of course it can occur at any time. Okay, this consolidation responds to treatment. So once we have started already, we already put our patient on this ATT medication, and then we are seeing this patches. Soon there is effusion is here, but that effusion, that fluid collection is actually in response to the medicine. Like if maybe the cavities are there and those cavities are going to get dissolved and they will give you this appearance. So again, you will find some consolidation, and especially if you want to see we have already administered that after some time period, see this consolidation will get resolved completely. So once the patient is on ATT, it will be resolved. So it's before ATT and it's after starting ATT. And cavitation, once cavitation also going to get resolved, so cavitation will be converted into consolidation. Like slowly you will see the reverse phenomena, and soon it will be disappeared. So this is before treatment and this is after treatment. So here you can see all cavitation is also there, consolidation is also there, and after the treatment you will see these are going to get resolved. Of course it will take time, but this cavitation is dissolved first, and then lastly consolidation will subside. If there is tuberculoma will always be there. You cannot always because this granuloma can be there for 100 years. It's like that. So you cannot easily remove the granuloma, but if cavitatory lesions are there, consolidations are there, that can be completely wiped off after giving treatment. Again, cavitation and consolidation we can find here, and after the treatment went away. So just think about this one, that in tuberculosis patient, you can find alone lymphadenopathy, you can find alone consolidation, you can find granuloma, you can find cavitation. So there may be 4 variants you can find in X-ray of TB patient. So now coming back to our slide. Okay, this one is barium. So if barium solo, so could you recall this picture? Barium solo is showing the bird beak appearance. This is actually the lower esophageal sphincter, which is going to or what is happening here? There's too much narrowing of the lower esophageal sphincter that is giving you appearance of bird beak on barium solo. That is especially a case of achalasia. So achalasia, so you can easily relate this one. Okay, now we're coming towards the ECGs. For the ECG point of view, please.
No, what happened?
No, nothing. What happened?
We will do that slide, na?
Which slide? It's done, right? It's done. You want some more about achalasia? It's very clear, but beak appearance.
No, I don't want anything more.
Yeah. Okay. Now coming towards the ECGs. For ECGs, you should know the basic, especially for the right bundle branch block and for the left bundle branch block. In order to differentiate, you should know the normal pattern of these QRS waves. So just starting with the beginning. Of course, it's very much beginning, but it's okay. It's always better so that you can easily relate when morphology comes, when pathology comes. So if you know the exact morphology of these waves, especially, then only you can differentiate with the pathological one. So just for the, for just a quick revision, we have seen this ECG paper. They are having some small blocks, and these small blocks all together, we are forming the big blocks. So one small box, and if you're taking this 5 blocks, so it will give you appearance of this one big block. So you must know that this one small block is always considered to be 0.04 second. And if you're considering the whole one big box who's having this 5 into 5, so 5 the 25 blocks inside, it will give you seconds of how many? 0.20 seconds. So this ECG machine pen marker is actually working at 25 millimeter per second. So this one small box is actually showing 1 millimeter. It means that in 1 second, the ECG marker can actually cover 25 small boxes. So speed is 25 millimeter per second. That's the normal speed of the ECG machine. But just for your knowledge point of view, just memorize this one, that small box is 0.20 second, and this 0.04 second, and the big box who's having 25 boxes inside is of 0.20 second. And especially if you are considering this one, the one large box, why this one large box is important for us? Because later on when we calculate the rate, it will give you a clue that in between these two R waves, if how many long boxes are there, how many large boxes are there. So whatever the number are there, we just divide that number with 300, and we will give a clue that what will be the heart rate in this patient. So we'll do this later on, but just now here. Now this one is the morphology of the waves. It's very important. First, always we have this P wave. Why the P wave is formed? Because of the atrial contraction. Once the atria contracts, both atria, right and left atria, when both right and atria contracts, it will give you this contraction wave, and that is called a P wave on ECG. Then what happened? Atria relax. So once atria relax, you will not find anything on ECG. In normally once the atria relax, it will not give anything on ECG. Now what will happen once atria relax? Now it's the time for ventricles to contract. So once ventricles contract, we will always receive this wave, and this wave is going to be divided into 3 waves. One is the Q1, which is going down. Which is going up is the R wave, and the one who's going down, again we will say it's the S wave. So this is very important. This one is Q wave, this one is S wave, and in between Q and S, this wave is having a pointer. This wave is called the R wave. So in between Q, R, and S, this is called QRS interval, and this QRS interval is showing the ventricular contraction, ventricular depolarization. Depolarization means contraction, repolarization means relaxation. So whenever we say QRS interval, we always mean this one, starting from this Q wave, and then this R wave, and this one S wave, from time period from here to here. So if you could just calculate these small boxes in between these, from this point to this point. So mainly 1 small box, 2 small box, and 3. So there are 3 small boxes where you can say the normal QRS interval should be between 3. So when I say the QRS interval is increased, it means that it will start from here and maybe it will end somewhere here. So boxes in between will be more than 3. So if the boxes in between these 2 waves, that is Q and S wave, if more than 3, you can say the QRS interval is increased. And we will see the pathology in which we have to memorize this one, that these are the conditions where we usually see increased QRS interval. So QRS interval is increased. It's not a normal thing. Of course, it's a pathology. Like ventricles, why ventricles are taking too much time to contract. Then when ventricle relax, we will always see this T waves. So once atria contracts, we will find this P wave. Once ventricle contracts, we will find this QRS wave. And when ventricle relax, we will find this T wave especially. So this way, this interval is also very important. We have to learn this one, that starting from the P wave and starting from the QRS wave, this is called P, starting from the P wave, and if we are considering this R wave. So this is called PR interval. This PR interval is very important because your all AV blocks are depend on this PR interval. We need to see in AV blocks, like in which condition the PR interval is same or PR interval is increased from beat to beat. So this PR interval is very important whenever we are doing this AV blocks, 1st degree, 2nd degree, 3rd degree AV block. We will see the ECGs of those blocks, and you should be clear in your mind that this PR interval should be PR interval should be normal. So if we can just consider the boxes there, 1, 2, 3, and 4. So 4 boxes are there in between P and R interval. And of course, this ST segment is again very, very important whenever this myocardial infarction thing is concerned, because if you could just see here, this ST segment starting from S till T, there is just a straight isoelectric line. There is no bumping in here. But once it's shift up, we will say it's ST elevation. So that is the thing which is pointing towards always myocardial infarction. And we will see some reciprocal changes in other leads as well. Whenever the word says reciprocal means that if you find ST elevation, simultaneously if you find ST depression in other leads, you can say it's a reciprocal change. And in most of the myocardial infarction, we can find some changes, ST elevation in one leads, and in other leads, maybe we will find ST depression. Then there we will use the term reciprocal changes. So reciprocal means that if simultaneously you are receiving both ST elevations and ST depressions in 12 lead system of ECG, we say these are the reciprocal changes. We will see later. Just now, it's very important that you should see this ST segment should be straight one. It should not be bumpy, it should not go up, it should not go down. If it's go up, we will say it's ST elevation. If it's go down, we say it's ST depression. Okay. So this is again for our basic knowledge, that how we are actually calculating roughly. We can calculate the heart rate. Heart rate calculation is very easy. These are the 2 R waves. So just calculate the big boxes in between these 2 R waves. Say for example, they have already calculated. Big box should have 5 small boxes inside. So this is 1 big box, 2nd big box, 3rd big box, 4th, 5th. So if you could see in between these 2 R waves, there are 5 boxes. These 2 R waves, and in these 2 R waves there are 5 boxes in between. So we should divide in order to calculate the number, in order to calculate the heart rate. We have roughly formula, and the formula is this one, that if you have to divide these number of blocks with 300 figure, so 300 divided by 5. So what you will get the answer, you will get the answer of 60. So here the heart rate of the patient will be 60. It's very easy to calculate. Just memorize the thing. You have to count the number of blocks in between, and always remember that we are doing this counting only on the basis when we have a normal sinus regular rhythm. Now, normal sinus regular rhythm means that every beat has the same R to R interval. There should not be a difference. Like say for example, in pathological condition, we will see like in one beat, 2 beats, the RR interval is this one, and in the other one maybe it's very decreased. The other wave can come here, and the other wave can go very, very, very far away. So maybe in that condition, we will say the rhythm is irregular. It's not following the same pattern. It's changing from beat to beat. So in that irregular condition, it's very difficult to calculate the heart rate. You cannot calculate the heart rate from this point of view. This is only whenever we have sinus rhythm. Sinus rhythm means that the distance between 2 R waves will be the same. Okay, so these are the normal values. Like for example, PR interval should be 0.1 to 0.20. We have already seen it should be 3 small boxes. QRS should be also 3 small boxes. It can be 0.06 to 0.10. QT interval is this one. This is only for your knowledge point of view. You should know that PR interval, if it's the PR interval is going to get increased, we will see these in pathology condition, we will find AV blocks. So there it comes. So these are the normal ages, especially in the newborns, we have high rate. See, you can see up to 160, it's normal even in the sleeping condition, and in awake condition, it's too much high. 3 months to 2 years, 190, 2 to 10 years, 140, more than 10 years, 6 to 100. And normal person, adult person, we always have 72 beats per minute. That's the average heart rate, but it should be in between 60 to 100. So when I say if the heart rate is below 60, I should always say bradycardia. And whenever the heart rate is more than 100, I should always say tachycardia for adult people. But in children, of course, the variation is there, and we can memorize that one. So whenever the heartbeat is less than 60, we'll say bradycardia, more than 100, tachycardia. So now this is the normal ECG. Normal ECG, why we are saying normal ECG? Because we have to follow the pattern. So in the first one, in the first beat, P wave is there, QRS pattern is there, and T wave is there. Then we have P wave, QRS, and T. And in between these two, if we are considering this one, if we are considering this one, there's the same interval. So the distance between these two is exactly the same between these two, exactly the same between these two, exactly the same between these two. So we say it's a normal sinus rhythm. Normal sinus rhythm means that the distance between two R waves should be equal, and every complex should be there. Every PQRS followed by the T, every T followed by the P, and then QRS and the T, and then again followed by the P. And if we check the here, if we check here PR interval, here also 2.5 small boxes, here also 2.5 small boxes, here also 2.5 small boxes, here also 2.5 small boxes. So PR interval is also the same. Nothing is changed. Everything is iso, everything is same. Every beat is same to same. So this is called normal sinus rhythm. This is the normal CT, normal ECG. And if we just calculate the heart rate here, how many boxes are there? 1, 2, 3, 4 big boxes are there. So I will divide 300 by 4, and whatever the result is there, if it's in between 60 to 100, I will say it's a normal heart rate. Okay. Now, if here we will see what is happening here. If you could just appreciate this one, what is happening here? Now calculate the boxes. How many
PR interval is decreased?
Okay, and if you could just count the boxes, first count the boxes, okay? Because we want to calculate the heart rate. Because the first thing is heart rate is normal or not.
Dr. Hira, just we were doing in my class in the medical school, till we do 130, 50, 100, 60.
Yes.
Like what was it? Please repeat that thing.
This is this one, which we have just covered. This one, 300. Like we always start the first block. The first, if these two R wave is only having one big box in between, like the second wave just come here, we can say it's a 300 heartbeat. Then two boxes, 150,
75, 60, 50.
Yeah, 300, 150, 175, 60. But this you can memorize or don't memorize it. Just calculate how many boxes are there. 5 are there. Divide 300 by 5. That's the answer. If 6 boxes are there, divide 300 by 6. If 7 boxes are there, divide 300 by 7. And then you can get the result. But of course, if you want to memorize, you can memorize 300.
This one is easy.
Yeah. Okay, if you could just check here. So here, how many boxes are there? 1 big box, 2 big box, 3, 4, 5, 6 big box. 6 big boxes are there. So 300 divided by 6, what will come? 50. So do you think it's 60? A normal heart rate?
300, 150, 100.
Just calculate what's the heart rate?
300, 150,
100, 75, 60, 50.
50.
Here the heart rate is 50. So do you think it's a normal ECG?
No.
It's not a normal ECG, although it's showing the sinus rhythm. The rhythm is sinus, like the distance between two R wave is exactly same, and everywhere P wave and then QRS and then P wave and QRS and T. So everything is normal, but only the heart rate is decreased. But still, we cannot say it's a normal ECG. We will say it's a sinus bradycardia. So sinus bradycardia means that whoever the patient who is having the ECG, which is showing everything normal, but the heart rate is decreased, that is less than 60.
Slowly.
Yes, because there the SA node is not working properly, because SA node is the main pacemaker of the heart. It has to contract the heart 72 times per minute. But if AV node is doing that function, that can go up to 60 beats per minute. If Purkinje fibers are doing that function, that can lead to 40 beats per minute. So that's why we can say maybe there is a nodal shift in there.
Please repeat this point. Purkinje fibers, please repeat this point.
Yeah, these are the heart rate. The heart rate formed by different things. Say for example, SA node forms SA node are responsible. They are called the pacemaker. Why they are called the pacemaker? Because they are responsible. Okay. Yeah, so that is 72. That's
coming from different areas.
Yeah, so AV node can contract the heart 60 beats per minute. Purkinje can cause 45 beats per minute.
Okay.
So here everything
will be at 60, huh?
AV node 60 and Purkinje 45.
Okay.
Yes. So here you will say this is the ECG showing sinus bradycardia. So why we are saying sinus bradycardia? Sinus means the rhythm is regular. The rhythm is the same. Like every PQRS complex is there, and R to R interval is also okay. It's not changed anywhere. Like 5 blocks are here, 5 blocks are here, 5 blocks are here, all same. But the only thing is heart rate is less than 60. That's why we are saying it's a sinus bradycardia ECG. So you can easily calculate if the ECG is there in front of you, just calculate the number of boxes between 2 R waves and then divide from 300. So here the 5 boxes are there. So that's why when we divide the 300 by 5, it comes, or 6 blocks are there, we divide this 300 by 6, 50 comes. It means this patient is having bradycardia. Now this one, what you can see in this one. If I can just see P wave is there, QRS and T, then again PQRST, 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 so complex are there, all complex are there, plus R2R interval is also good.
Interval is same, but the
Now if you could calculate the heart rate, how many boxes are there? Exactly, one big box I can find here, and small portion here, maybe I should count it half box. So it must be in between 300 to 150. So what do we mean by this one? It means it's more than 100. So whenever everything is normal, like PQRS complexes is there, but the distance between 2 R wave is more than 100 beats per minute, coming more than 100 beats per minute heart rate, we will say it's a sinus tachycardia. So sinus tachycardia is again a normal. We will not say it's a normal condition. Of course, the heart rate is heart is under much activity. But of course, it's one of the things we can say sinus tachycardia. So whenever we do jumping and exercise, of course, we usually have this sinus tachycardia in that condition. Or we are in stress, we can also have the sinus tachycardia. Okay, now this one. What is this one? What you can see in this picture?
Here heart rate is even less, very less.
If you can see here, the very first thing which you can see here is R to R interval. Do you think this R to R interval is exactly the same with this one?
No.
Or this one is exactly the same with this one? Of course not. And here again, this one, these two and these are same, but this is different. It means that, but I can see PQRST normal. I can see again PQRST, BQRST. So complexes are normal, but R to R interval is different. So we will say it's that this patient is having sinus arrhythmia. Sinus arrhythmia means that the heart rate is okay. Heart rate is usually normal, because calculate the boxes. If we can calculate the boxes 1, 2, 3, 4, 5, maybe 6, or here if we can calculate 1, 2, 3, 4, 5. So we can see the heart rate is around between less than 100. But what is there? The major thing, the R to R distance, we cannot find regular ones. That is irregular one. So whenever you will find something like this one, where R to R is different, but the complexes are all normal, we can say it's sinus arrhythmia. Arrhythmia means that you will find some changes, irregular pattern in there. Like sometimes the heart is taking too much time to relax, sometimes heart is taking too much time to contract. You can say it's sinus arrhythmia. But honestly, in your exam point of view, you will not get this sinus arrhythmia. For our exam point of view, if I'm considering DHA, they usually give ventricular tachycardia, they usually give atrial fibrillation, they usually give supraventricular tachycardia, and the last one, this torrid depointus, where we can see this spindle shape ECG. Only these 3-4 ECGs, but of course you should know at least very common ECGs. See, this atrial flutter is very important. Atrial flutter, we know very well, whenever this flutter and fibrillation are concerned, in these conditions actually there are too much activity. If you're considering atrial, it means that atria are contracting again and again and again, and they are not taking time to relax at all. We will find that we will say this is atrial flutter. So here what we can see here, so you will always find this flutter waves. This P waves is actually going to convert into a flutter wave, because whenever atria contracts, we can say it's a P wave. So always in atrial flutter, you cannot differentiate a proper P wave, and maybe you can find too many P waves here, 3, 4, 5 P waves here. We should not say P waves here. We will always say here flutter waves. So flutter waves have sawtooth appearance. Some may be buried in the QRS complex. You cannot differentiate, because here the QRS complex should come, but here the QRS complex is not here, and it's showing it's buried somewhere here, and it's not visible. So that is called flutter wave. So if you could find some ECG like this one who's having this sawtooth appearance, and you cannot easily differentiate QRS complex in between, and again the heart rate is very high, you can say this is atrial flutter. So flutter, just saw this one, it's showing sawtooth appearance, so that you can differentiate with fibrillation. In fibrillation, you can see only just very small indistinctions. There is no proper sawtooth appearance. So if you could just differentiate with this fibrillation, This is fibrillation. So if you could just differentiate this one, here you cannot saw proper sawtooth appearance. Here you can see a very irregular and this indistinct
Small
P
waves,
waves. These
small
are not called true P waves, very small, very chaotic P waves you're going to see here. And of course, heart rate is increased, and this RR interval is also not going to be the same. If you can appreciate here in this picture, the RR interval is same. Can you see this one? This R2R, this R2R, it's mostly same, almost same, right? This R2R, if they are all equal, these R2R interval is equal. But in fibrillation, see this R2R and see this R2R, it's too small. This one is too big. This one is too big. This one is too small again. This one is very big distance, very long distance between two R waves. So remember this one, in atrial fibrillation, this R2R will be very much. Plus, you will find this indistinct and chaotic P waves. While here, the R2R is almost equal, is same, but only you will find this sawtooth appearance. You will not find some QRS complexes in between. And this sawtooth appearance is very much common in. And this sawtooth appearance is called actually the flutter waves. So this is called atrial flutter, and this is atrial fibrillation. Okay, this one is very important for your exam point of view. This one is ventricular tachycardia. We will see only the QRS complex. This is actually the QRS complex, which is going to appear like this one. This is actually showing that ventricles are in a very much stress condition. They are contracting a lot and they are not getting time to relax. So this is called ventricular tachycardia. Remember, in ventricular tachycardia, you will have the regular thing, like regular pattern is there, but there is no QRS complex. Nothing in there. Only you will find QRS complex, which is converted into this monomorphic wave. This monomorphic wave is actually the QRS complex, and this monomorphic wave is called VT, ventricular tachycardia. So in ventricular tachycardia, you will not find anything, no P wave, no QRS, no T wave. Only one monomorphic wave is there, which is called ventricular tachycardic wave, and it's showing the same pattern. The regular pattern is like this. There will be no change in this pattern. Of course, this is not a regular pattern, but for this ECG, it's a regular pattern of this monomorphic wave. This is called ventricular tachycardia. So please see many pictures of ventricular tachycardia so that you can memorize this one, because this is very important for your exam point of view. This one is torsi de pointes. Again, you will find the same ventricular tachycardia in this ECG, but here you will find sometimes this pattern appearance. This is called a spindle effect. So if this bizarre appearance is there, then we can say it's a torsi de pointes. So in your exam point of view also, you're going to see these are the twisting. In French, the term means twisting of points. So sometimes these points are twisted here and here, and you will find typical monomorphic waves, and then this twisted point comes, and then it followed by monomorphic waves, and then twisted point comes. So it will give you a spindle effect. It will give you a spindle shaped appearance. You can say this is torsi de pointes. This is very peculiar, very much appreciable. Okay, ventricular fibrillation. Now, if you could just compare this ventricular fibrillation with atrial fibrillation. See, in atrial fibrillation, there were proper complex of this RR. R was proper. Okay, there was no proper regular interval between these two RR, but we were having this small fibrillating waves. But if we are considering with this ventricular fibrillation, what you can see here, it's the same monomorphic waves. Here you are seeing this in a sawtooth form, like sawtooth appearance. Can you see here? They are actually having indistinct margins here and here. And of course, they are not monomorphic. See, this one is big, this one is small, very small, then big, then small. So the pattern will be like sawtooth, but of course, there is no R in between. So you cannot say this one is atrial flutter, atrial fibrillation, and not very much indistinct fibrillating waves. Rather than that, these are the same QRS complexes, but these QRS complexes are showing are not monomorphic. Then we can say it's ventricular fibrillation. Can you appreciate this picture with this one? Here, every wave is monomorphic, same wave. So if every wave is same and monomorphic, and as compared to the fibrillation is big, then you can say this is ventricular tachycardia. And when you can say ventricular fibrillation, these are having sawtooth appearance. They are not monomorphic. And again, these are the QRS complexes, but they are smaller as compared to monomorphic waves.
No,
So,
doctor, in atrial fibrillation, the waves are very large, tall waves. Here, very small waves.
yeah, so in ventricular, this one, ventricular tachycardia, they are the large one, right?
Yeah.
And if you're considering with the atrial fibrillation, in atrial fibrillation, we have proper R wave, but in that condition, we don't have any R wave. We have only up till here. But here we can easily differentiate these R waves, and then we have this fibrillating waves. These are actually the P waves, which are forming this one, because this is atrial and this is ventricular. So ventricular means QRS complexes here. So this is actually a QRS complex who is going to convert into a fibrillating wave. But this is of course a ventricular fibrillation. Here you will find a small wave as compared to ventricular tachycardia. Ventricular tachycardia, monomorphic big waves. Can you appreciate?
Yes.
Because sometimes sometimes people find it difficult, you know, in between ventricular tachycardia and ventricular fibrillation. The only difference is that they are indistinct, they are having sawtooth appearance, they are big and small, so no monomorphic phase, right? And here in ventricular tachycardia, they're all monomorphic and big.
No, in the ventricular tachycardia, the rate is increased, but in
Yeah, it is increased.
fibrillation, only heart is fibrillating.
Fibrillating, yeah. So one time we can, yeah.
Fibrillating.
Yes,
And
yes.
this, power is reduced.
So voltage, you can say voltage is high, heart voltage is high, and
voltage is decreased here.
Yes.
Voltage is decreased here.
Okay, now coming to this AV blocks. These AV blocks are very important. So you can also find this in your exam. So please be vigilant about this one. First degree AV block. So for first degree AV block, first thing we will see the rate. The rate we will see here depends on rate of underlying rhythm. So if you could just see, it's all regular rhythm. How I can say it's a regular rhythm? Because distance between two R waves, it seems same, right? Same in between all R waves, the distance are okay. And then P wave we could see, if you could see here P wave, it's normal P. But if you can see the distance between P to this Q wave, do you think this distance between P to Q wave is normal?
No.
Of course not normal, because just it should be 2 or 3 boxes. Now if I can calculate 1, 2, 3, 4, 5, 6, 7, 8, 9 boxes are in between. But still, if I compare this one to the other bead, this is the same one. Then compared to this one, this is the same. So of course PR interval is increased, but that is following the regular pattern. Means if PR interval is increased here, then it's also increased here, then it's also increased here. The same pattern, increased pattern is following. So prolonged but same PR interval. So if on ECG strip it's showing the same PR interval but prolonged PR interval, other than that everything is normal, we can say it's a first degree AV block. So only for the first degree AV block, what you're going to check in your ECG, the distance between P and Q wave. If the PR interval or R wave, if the PR interval is prolonged, and then check with the other beats also. If you find every beat has the prolonged PR interval, it means that that is the first degree AV block. Got it? So in first degree AV block, you will find everything normal pattern, normal rhythm, but what is there? Only prolonged PR interval, regular prolonged PR interval. But what happened in this one? Yes,
we have missed this. What is this baseline line? What is showing is polarization up the line and down the line. This we have not done.
Which one? Which line, doctor?
Like this. This is a medial line, medial line between the P wave and then Q wave and up and down. So what position is showing up, going up the medial line, which is going down?
I cannot follow you. You're asking this one, that which kind of wave is this one? This one is Q wave. The one who is going up is R. The one who is going down, this one is S wave. If you, I could just show you in this one.
No, not
the
this
first
one.
thing
Not this
you
one.
are asking this one.
Like, see, but we know there's the waves going up the line and coming, like R wave and T wave are up, the Q and S are down. So what's
you are considering about the axis. Axis. It's okay, but here we are not bothered about axis. Because
no, just tell us what is the axis.
Okay, okay, I will let you know later. Okay, just come to the pathology first. Axis usually showing the current activity, because we usually put this 2, 3 AVF leads, that is corresponding the natural axis of heart, that is minus 59 degrees. The axis of heart should be minus 59 degrees. So if you put the leads in such a way that it should mimic the normal heart axis, which is minus 59 degrees, that is always showing you the positive deflection. Positive deflection means that everything will come straight up. But if you put the leads in such a way that it's going away from the normal axis, it will always give you a negative deflection. Negative deflection means that everything you will find below the line. But that is, of course, the normal thing. But because you have put the leads in a wrong position, that's why you're getting the wrong ECG. It's totally upside down. So, but just remember, the normal axis of the heart is minus 59 degrees. And this lead 2 is the one which exactly follows the heart axis. Lead 2 axis is minus 60 degrees. Our normal heart axis is minus 59 degrees. So that's why whenever we are considering ECG, we always take this lead 2. So whoever ECG I'm showing you, always, these are all lead 2, because lead 2 is showing the main axis of the heart. That is minus 59 degrees. Lead 2 axis is minus 60 degrees. So that is the most closest one. So all ECGs, all ECGs are lead 2. Lead 2. They all are lead 2. That's why everything is showing above the line. Okay. So now come here to this.
They are also
Can we
showing
go?
down. They are also showing down the line, just in theory.
Yeah, there are. But whenever we have ST depression, what we can see? We can see it's going below, but that is a pathological condition. That's why in lead 2 also you can see ST depression. Other than that, why the ST depression should be there in normal ECG? There should not be ST depression. Of course, there's a pathology. That's why it's showing ST depression. But what if you are taking only the lead AVF, or you're only taking lead AVR? In that condition, maybe you can find negative deflection. So normal ECG will also be on. You are going to see below the lines. I will show you later.
Okay.
First, complete this one.
Okay.
Okay, now we have this second degree heart block. So for second degree heart block, we have to divide the second degree heart block into 2 types. One is called type 1 and one is called type 2. So we have this type 1, which is called Mobitz type 1 or Wenckebach type 1. So now what we are going to see in this one, in second degree type 1. In second degree type 1, if you could appreciate this, RR interval is changed. RR interval is changed in the way, if you could just see here, this is okay, this one is okay, but here there is a missed beat. And why the missed beat is here? Because there is a pattern. There is a pattern of PR interval, which is called progressively longer until one P wave is blocked. Now, if you could just calculate here, this PR interval, if you could see this black line, is a small. Now, if you calculate the PR interval, it's increased here, so many boxes. So it's showing with this line. See, PR interval is increased. Now, in the next beat, the PR interval is more increased. So first PR interval is short, and then it's large, and then it's larger, and then it's too much that it's actually showing the missed beat. The whole QRS complex is missing here. And then again, starting with the small, and then large, and then larger, and then again, it's going to show you the missed beat. So if the ECG follows this pattern, where you will see the PR interval is short, and then large, and then larger, and then missed beat, then large and short, then large, and then larger, and then missed beat, then you will see missed beat means that there is no QRS complex. P wave, directly you will see this P wave, no QRS complex, and again you will see this P wave. So if the whole QRS complex is missing in a pattern where we see the PR interval is getting increased slowly, and then there is a missed beat, we will say it's a type 2, it's a second degree type 1 AV block. Second degree type 1 AV block. And what are the features in there? You can just go over the theory. The features are here for our example, for your only knowledge point of view, that when you check the PR interval, it will progressively increase, and then suddenly there's a missed beat, and then progressively increase, and there's suddenly a missed beat. Then we can say it's second degree type 1. Another name is Wenckebach. Now for type 2, what we will see? In type 2, if you could just appreciate here, what we can see, First of all, this RR interval is changed. See here, the RR interval is this much. Here is so small. Again, this too much. So there is no proper RR interval here. Then PR interval may be normal or prolonged, but not constant. Here, if you could see, there are only two small boxes, which is the normal one. Here you can see 2.5. Here you can see 2.5. So it means sometimes you can find normal. Sometimes even you can find prolonged also, but it's not the constant one. And there is no there is missed beat here as well. You can find it here. See, there is no PR or QRS complex. So here there is no pattern like that where the PR is actually prolonging. Say for example, first short and then long. Say for example, if I take you back, here you can easily say that first the PR interval was short and then larger and then largest and then missed beat. But here what you can see, the PR interval is almost same. Here is also the normal, here is also the normal, here is also the normal, here is also the normal. The PR interval is normal, so it has nothing to do with the PR interval. Only the thing is that you will see missed beat, and this R2R interval, of course, is irregular. So R2R interval is irregular. There is a missed beat, but PR can be normal or PR can be prolonged, but there is no follow pattern. There is no pattern like prolongation of PR interval slowly and progressively. There is nothing like that. Then we can say it's a type 2 secondary AV block. In type 2 secondary AV block, you will find missed beat pattern, but you will find normal PR interval. Plus, of course, the rhythm will not be a regular one. So here they have mentioned conduction ratio. You can see there can be 2 P wave and then 1 QRS complex, or maybe sometimes there are 3 P waves and then 1 QRS complex, and sometimes maybe there are 4 P waves coming together, and then you can only find 1 QRS complex. So there's a difference between like ventricle contraction are getting low in this type. So this is called second degree AV block. Okay, for third degree, what we will see? For third degree, the first thing we can see here, if you could just... Yes, dear.
Sorry, but here the QRS Q wave is upright height is very much. Its height is
yeah. This one, if you are saying this one, this S wave, S and T wave, you are saying this as depression. These are these are not exactly, we can say ST depression, but these are going too much down. It's showing ischemia. This is showing ischemia. These are too much depressions here. These depressions are showing ischemia.
They are said this is avoidant and the upright wave is very long.
Upright wave, you are saying this R wave, right? R wave is approximately the same.
This R wave,
this is S wave. This is S wave. The down wave is S wave. So this down S wave is actually showing ST depression. So this ST depression is pointing towards ischemia of the heart. There's ST depression, right? This one is ST depression. This S wave, and when it comes with the T wave, you can see it's all down. It's not iso. You remember, it should be straight. It's not straight. It's getting down. It's showing ST depression, and S wave is going too much down. If
also
Q wave,
see this Q R wave has 3 small blocks.
see, this PR interval is okay. Na? PR interval is in between this.
R wave is going up with for 3 blocks.
3 blocks? Yeah. This one, this R wave is okay. R wave is okay. See, in relation to every R wave, you can see it's all okay. They are on the same height. 3 blocks are there. Yes, 1, 2, 3, almost 3.
It's normal than usual, no?
You can say maybe, but it's okay. In normal condition also we have this much. Show me. It's 2 blocks. Okay, you are saying in this way, and that's compared to this way.
Yeah.
Okay, prolonged R wave. Yeah, you can say.
See here. See here, R wave and even S wave is small.
Yeah,
F wave only
it's showing
one block. Only one box. There are 3 boxes.
Yeah, you can say that. Okay, got it. Got your point. You're saying that this R wave is getting taller R wave. We are getting taller R wave. Yeah.
Taller and widened S wave. ST is also widened.
So that widened, the term which you are saying widened, we are saying in the form of PR interval. PR interval and of course QRS interval. That is the same thing. You can say in late term widened, but it's better to say PR interval is increased and QRS interval is increased. Okay. So now coming back to this one, third degree AV block. Now for the third degree AV block, what you're going to see here, you will appreciate here the rhythm usually regular. Why I'm saying the regular rhythm? Because if you could see the distance between two R waves, they are normal. See the distance over here, the distance over here, the distance over here, it all looks same. So it means that the regular rhythm. But now if you can see the P wave, so P wave, they're also saying they are normal. See, P wave here is also P wave, here is also P wave, here is also. But what if the PR interval? PR interval varies greatly. So if you could just see here from this to this, it's too much. This is again very low. Here we have missed beat. We cannot find anyone. Here we can see normal PR interval. So here normal PR interval, here too much increase, here too much decrease. There is no particular or follow thing is there. It means that the PR interval is greatly varied. Now, QRS complex. If you could see the QRS complex, normal if ventricles are activated by junctional escape foci, wide if escape focus is ventricular. So see, if you can see the QRS, so QRS complex, you will find Q wave, R wave, and then S wave. And of course, S wave is showing down, it's showing the ischemia, but QRS complexes are there. So QRS complexes will be there, but the most important thing, the heart rate. The heart rate you are going to see must be less than 40. So now if we can calculate the boxes in between them, 1, 2, 3, 4, 5, 6, and I can calculate this as 7 as well. So 300 divided by 7, it means it's less than 40. So heart rate is very small, very, very, very low. It is very low, up to 40 beats per minute. So if heart rate is up to 40 beats per minute, it's not the PR interval, it's showing very great variation. Sometimes it's normal, in other beats is very high, in other beats it's low as compared to the previous one. There are missed beat also. But the only thing is this, the regular rhythm is there, like R to R distance is okay. Other than that, everything is down. Heart rate is down, the normal PR interval is not there. Then you can say it's a complete heart block. This third degree heart block, complete heart block, is the indication where we need to put pacemaker, because here we have to advise the patient, we have to put our patient on pacemaker so that this rhythm can be controlled. So what we are going to memorize in the third degree heart block, first of all, heart rate must be 40 beats per minute. That is the first thing. Rhythm can be regular. PR will be greatly changed from beat to beat. And then QRS complex can be normal thing, but of course showing ischemia pattern. So that is third degree AV block. Okay, this diagram is actually showing you the position of leads in comparison to myocardial infarction. So we have this, especially if you are considering lead 2, lead 3, 2, 3 AVF. So these 2, 3 AVF leads, whenever there is some problem to these 2, 3 AVF leads, we will see in terms of inferior thing. What these are the leads which are representing the inferior part of the heart. They are representing the inferior part of the heart. So if anything happens here, what things can happen here? Of course, ST elevation, we are considering ST elevation MI. So then we can say that would be a inferior wall MI, because we know very well these three leads are representing the heart axis of inferior wall. Inferior wall heart axis are represented by lead 2, lead 3, and lead AVF. So whenever there is something wrong in here, we will say inferior wall MI. Now, lateral one, we usually say, especially this lead 1, V5, and V6. So for lateral wall, we will see these three leads, L1, lead 1, V5, and V6. So whenever any pathology comes here, we will say, and by pathology means ST elevation or ST depression. So we will say lateral wall MI. Now for anterior one, we have V1, V2, V3. And for septal also, we have this V4. Sometimes we can say anterior, sometimes we can say septal. It's okay, but it should involve V1, V2, V3, and V4. So if we are taking only these 4 leads into consideration, and we will see if any ST elevation in there or ST depression in there, we will say it's an anterior wall MI. And sometimes all the walls of the heart can involve. So maybe sometimes you can see inferior posterolateral MI. That can also be happen. That is called extensive MI. Extensive MI is showing 2 or more than 2 wall of the heart if are involved and showing you some changes in the ECG, then we can say it's an extensive MI. It's showing 2 or more involvement of layers. If only lateral wall is involved, we can say lateral wall MI. If only inferior wall is involved, maybe both of these involved, we can say inferolateral, anterior, inferior anterior posterior, or anterolateral or anterior posterior. So there are many terms we can say, but that always indicate extensive MI. Extensive MI means that when more than one wall of the heart are involved. So now if we go here, so now if you could appreciate here in this one, this is the ECG of extensive. If, by the way, for your exam point of view, you will never get ECGs related to MI. Honestly speaking, I have never ever seen for the last 5 years, there is no question related to MI. But of course, you should know, because it's too much in routine practice. In your clinical practice is going to help you, and it's not a matter of 1 or 2 times reading of ECGs. A lot of time you have to see the ECGs just in order to practice yourself, in order to see MI in your patient. Sometimes it is very, very obvious. So we are here only to see the obvious thing in the ECG, so that we can easily say, okay, the MI is there or not, or if MI is there, then what kind of MI is there, which wall is involved, interior wall is involved, inferior or lateral, posterior, or all walls are involved. So if we are considering this anterior ST elevation MI, so we know very well for anterior thing, which leads we are going to see? We are going to see V1 to V6. So if in between V1 to V6, if you can find ST elevation, then you can think about that's the interior wall MI. So now let's have a look at here. If you can see, this is V1. So in V1, you just don't forget about this QRS complex, P and QRS complex, which is getting down. But if you could appreciate this ST elevation here in V4, if you could just appreciate, because that's a negative deflection. So I'm not considering this V1. Now considering this V4. In V4, if you could just appreciate this one, P wave, this Q wave, QR, R, S, and now the T wave is very high. Now you can clearly see this is the ST elevation. It's very much marked here. Again, you can appreciate your ST elevation. This is ST elevation. This is ST elevation. This is ST elevation. Again, this is ST elevation. V3 also showing ST elevation. V6 also showing ST elevation. So these big waves which you are seeing, actually these are nothing but these are the ST segment which is elevated, which is showing you that this patient is having myocardial infarction. So that is the first sign which you are going to see, especially in these V1 to V6, is if in between V1 to V6 you can find, and especially in AVL also. AVL lead also. So in AVL lead also, see, this one is high. This is the PQRS complex, QRS complex, and this is the ST segment. This ST segment is also high as compared to the normal person. Here also you can see this ST segment is high. So this is the anterior wall MI. In anterior wall MI, which leads you are going to see? Always look for the leads V1 to V6. Now they are saying minimal reciprocal ST depression in 3 and AVF. You remember I told you before, whenever the word reciprocal comes, always think reciprocal means that if in the same ECG you will find ST elevation and ST depression together. That is called the reciprocal change. Reciprocal change means that in one leads you find ST elevation, and in the other leads you find ST depression. Now they are saying in anterior wall MI, in lead 3 and lead AVF, we can see ST depression. Now look at here. This is lead 3. So this lead 3 is showing ST depression. Here also it's showing ST depression. So if ST depression is there in lead 3 and lead AVF, that is called a reciprocal change, and that can also be seen in anterior wall MI. So in anterior wall MI, you will see ST elevation in V1 to V6, but you can also see ST depression, reciprocal change in lead 3 and lead AVF, and reciprocal change means that ST depression in lead 3 and lead AVF, that is called anterior wall MI. For your knowledge point of view, you can just think about this one, and then you can also find some PVCs here. PVCs means that premature ventricular contraction. But again, this is not hard and fast rule. PVCs you can find anywhere during the ECG. PVCs means that you can find this small QRS complexes soon in between. Say, for example, this QRS complex, and again it's followed by this QRS complex. So it has taken no time actually. It just soon in between a normal rhythm. So this is called PVC. Any premature ventricular contraction which occurs soon after a normal contraction, that is called PVC. So PVC is just a additional thing you may find, or you may not be, you may not be able to see it. So, but just memorize this one for anterior wall MI, that V1 to V6 will be showing ST elevation, and reciprocally, if you can see in 3 and AVF, there is ST depression. You can say it's a purely anterior wall MI. Now for inferior wall MI, for inferior, you remember for inferior, we have to look for lead 2, 3 and AVF. So 2, 3 AVF, if it's going to show you ST elevation, we will say it's an inferior wall MI. Now just have a look here. 2, So now 2. Now you can clearly appreciate here. ST elevation, here again ST elevation, here again ST elevation, ST elevation. So 2, 3, and then in 2 also ST elevation, here also ST elevation, and AVF. This one is AVF here also. So in 2, 3, and AVF, if they are going to show you ST elevation, you can say this is the inferior wall MI. And not only this one, you are also going to see Q wave formation. Q wave formation means that the Q wave usually forms soon after having a myocardial infarction, maybe 2 to 3 hours later. If the patient comes to you with a history of myocardial infarction, just 2 hours later, you can see even Q waves in those patients, and after 24 hours, if the patient comes to you, then also you can see. And in if the patient was having myocardial infarction, say for example 5 years back or 6 years back, then you can see all big Q wave in those patients as well. So whenever the Q wave is there, it's actually going to show you that this patient is having MI, and Q wave is particularly for MI, recent attack also, and the previous attack also. So you need to inquire from the history. On the basis of history, you will rule out that this is the previous Q wave and this is the latest Q wave. So here you can see.
Please show us the Q waves here.
The 3 in 3 you can clearly see this is just long deflection down here, because if I just show you with the normal one, just appreciate this normal one so that you can easily relate with this one. See, this is the Q wave, only this much who's going down and then coming up. So the one who is going down is Q wave, only this much from here to here, because once it's go up, it will start to become R wave. So this one who is going actually down at the end of the P wave, the wave who is going down is the Q wave. Now the picture which I'm going to show you now, it's showing more deflection here and no R wave. Now look here. So if you could just see here in this lead 3, this Q wave is getting too much down and R wave is only this much, little much. And then S is actually converted into this ST segment elevation. S is just merged with the T and forming this ST elevation. And this Q wave is getting too much deep. It should not go too much deep, but if it's going too much deep, it's a pathological Q wave. It's showing MI, myocardial infarction. It can be an old one, it can be a recent one. But if it's very big waves all over the ECGs, then you can say it's a previous infection. But again, in the history, you can rule out. So now you are clear with this Q wave. It's getting too much low, and R wave is just a little bit, and S is merged with the T. So we can say this ST elevation. This elevation, ST elevation MI, is inferior ST elevation MI. Why we are saying inferior? Because which leads are involved? 2, 3, and AVF are involved. So you will look for this one. Now for anterolateral. Anterolateral, 2 things you are going to see. Anterior also and lateral also. So for anterior, of course, we will look for V1, V2, V3, V4. And for lateral, we will look for lead 1, AVL, V5, and V6. What we are going to see here, we want to see ST elevation here. So if ST elevation here in V2, V3, now see here, V2 big elevations are here. All over V2, V4, we will see big elevations. Now we will see lead 1 also. See lead 1, this one. Elevation is here. ST elevation is here. AVL, ST elevation here in AVL. V5, here you can see V5 and V6 here. So when V5, V6, 1 and AVL involved, we can say it's a lateral MI. And when V2 and V4 are involved, we can say it's anterior MI. And when we see all together, we will say it's an anterolateral elevation, ST elevation MI. So whenever there is an anterolateral ST elevation MI, we can see some reciprocal changes again in 3 and AVF. Reciprocal changes means that you are going to see a ST depression in these leads. So and now see, this is a clear depression here. Clear depression here. It should be above the line, but once it's below the line, it's showing to here also.
Here, please show in the V5 and V6 ST elevation.
It's clear there. Here, this one. The QRS is so small and ST elevation is so big. 6 also, see this QRS is so small and elevation is so big. ST segment elevation is so big here. So this is V5, V6. Yeah, this one and this one.
Here we cannot even appreciate QRS
wave. Yes, you cannot appreciate.
See, here even we cannot appreciate QRS wave.
Yes, of course. That's the thing. So you will remember in 3 and AVF, there will be depression. So 3 AVF showing depression, V2 to V4 showing elevation, 1 AVL, V5, V6 showing elevation. That's the anterolateral MI.
I cannot hear you.
Cannot hear me? Now can you hear me? Hello, are you there? Tyra?
Oh, I was like, sorry, cannot hear you. Voice was distorted.
Okay, okay. Now can you hear?
Yeah, I can hear you now.
Yes, we can hear.
Okay, thank you, dear. Thank you. All right. So now we will see here. This one is inferior posterior lateral. You will look for every lead related to inferior side, posterior side, and lateral side. So especially if you look for 2, 3 AVF and 1 V5, V6, if you see especially here, this ST elevation, we will say it's an inferior posterior lateral. Now look one by one. In lead 2, here is ST elevation. Lead 2. Then lead 3, here is ST elevation. Lead 3, here is ST elevation. And then AVF, here is ST elevation. Here is ST elevation. We can appreciate. Now in lead 1, here is ST elevation. Again, here is ST elevation.
Okay.
Then in V5 and V6, see it's clear, very clear here. V5 elevation here and V6 elevation here. So this is ST elevation, especially in terms of inferior lateral. Now you will see ST depression also in V1 to 3 with tall, broad R waves and upright T waves and RS ratio more than 1. So now we'll see ST depression in V1. This is V1. Now see, you can see here ST depression here. This is ST depression. It should go up, but it's coming down. This is ST depression in V1. Then V2 also, see, it's too much depression here. It's going down, and then the normal T wave is here. This is a normal T wave, but this ST segment is too much depressed. It's below the line. The line should be here, but it's below the line. Similarly, in V3 also, it's below the line. The line should follow here. This is a normal T wave, but the S wave is here. But this T wave, the S and T in between this segment is actually going down below this line. So this is ST depression. So in V1 to V3, there is ST depression, and 2, 3 AVF and lead 1 and V5, V6. If there is ST elevation, we can say it's inferior, posterior, lateral ST elevation MI. So you the main proximal circumflex artery when involved, that's the main culprit who is causing this inferior posterior lateral MI. Okay, for this one, right bundle branch block. Now, right bundle branch block and the left bundle branch block, they are the vice versa. So once you read for the right bundle branch block, just opposite is left bundle branch block. So we mainly look for 2 leads in both of these conditions. Either for the right bundle branch block or for the left bundle branch block, we usually see V1 and V6. So if you could just see here in V1, there is RSR pattern. RSR pattern is this one. If you could just appreciate this one, the R wave is here, and then again a big R wave is there, and then S wave you can find here down. So this is called RSR pattern. RSR pattern, why we are saying this RSR pattern? First, there is a small R wave, then small, we know very well the R wave goes down and it forms the S wave, and again we are going to see R wave in these patients, and then there's a T segment, ST segment, so we can say this is RSR pattern. RSR pattern means that we will find actually 2 R waves here in between S wave. This is called RSR pattern. And because of this RSR pattern, can you imagine what alphabet is forming here? See, it's going up and down and then up and down. It's M-shaped. This M-shaped. So if you can appreciate this M-shaped appearance in V1 because of RSR pattern, and you can appreciate this W pattern in V6. See W pattern. It's going little bit down, Q wave, and then R, then S is going down, and S is very indistinctive. See, S is like tooth saw appearance, but downward deflection. It's not, the counters are not clear. The counters are indistinct. Can you appreciate this one? This counter is so much sharp, and this counter is double sawtooth-like appearance. So if you could see here the W pattern, and this W pattern is forming here, then you can say it's actually it's a right bundle branch block, which show M pattern here because of RSR pattern, and it can form widened slurred S wave this widened slurred S wave in V6, we can say it's this W. W is actually saying this one because of this indistinct portion here. That is called right bundle branch block. So whenever you saw W pattern and M pattern because of RSR wave or because of this widened and slurred S wave in V6 especially, that's a right bundle branch block, and completely vice versa of this one is left bundle branch block. See why I'm saying vice versa? Here in V1 you are seeing M wave, but here in V1 you are seeing this sawtooth W shaped wave. That's the complete opposite of that one. So here in V1 we see M wave, but here in V1 we see W wave. So if here we see W wave, and now here in V6 we are seeing this M wave, this RSR pattern. So RSR pattern here is in V6 wave, while RSR pattern here is in V1 wave. So it's a complete opposite. So just memorize one, and then you can just do the opposite for the next one. That is the complete left bundle branch block. Yeah. You got this point of Tyra? This right bundle branch and left bundle branch block?
This little difficult, and also the internet is not good. Internet is not good. I don't know what with your mind.
Yeah, maybe you could go over the recording, but for your exam point of view, they are not going to give you right bundle branch block and this one ECGs, but they usually ask this RSR pattern and M shape pattern. So whenever it says M pattern you will see especially in bundle branch block. But if you see this M pattern, especially this M pattern in V1, that is right bundle branch block. If this M pattern is showing in V6, that's a left bundle branch block. Okay. So that's all for today. Thank you so much everyone for joining. I'm just going to share this PPT in the drive. Plus I'm going to share practice MCQs as well.
Thank you very much, Dr. Hira. It was very nice studying with you, and you taught in a very nice and good way.
Yeah, thank you so much. And thank you so much everyone. Bless you all.